Hi, in this video, I'm going to talk about the joints of the body. So as we go through the course, we'll go into more detail on most of these joints later on, and we'll talk about the functional anatomy of these joints. But for now, just kind of a brief overview of the joints of the body, the types of joints they are, what kind of actions they can perform, and so on. So starting with the shoulder complex or the shoulder girdle is incredibly complicated, probably the most complicated of any joint complex in the body. It includes four different joints as part of the whole shoulder girdle. The first is the sternoclavicular joint or the SC joint. So the sternoclavicular joint is a saddle joint, and that's what we see in this bottom picture here. It's the articulation between the sternal end of the clavicle and the manubrium of the sternum. The acromioclavicular joint, we see that up in this top picture. That's the articulation between the acromial end of the clavicle and the acromion process. So it's all the way in the top part of that top picture there. So it's kind of on top of the shoulder. It's superior to the glenohumeral joint. Um, Both of these joints, the sternoclavicular and the acromioclavicular, are only capable of gliding motions. So any of the actions that we talk about of the shoulder, we're not talking about the sternoclavicular or the acromioclavicular joints. So like flexion, extension, elevation, depression, and so on, those are all actions of the scapulothoracic or the glenohumeral joints. The SC and the AC joints only glide. The acromioclavicular joint is a plane or a gliding joint. I guess that's all I have there. Here, let's keep going. The other two joints of the shoulder, we have the scapulothoracic joint. That's the third one. That is not technically a joint. So we've talked about types of joints and how we classify joints, and there's no, the scapulothoracic joint does not fit into any of our joint classifications. So technically it isn't actually a joint. With that said, we do refer to it as the fourth joint of the shoulder. So you'll hear me constantly talk about it as a joint, or like there might be quiz or homework questions, things like that, that talk about like name the four joints of the shoulder. So we count it as a joint. We describe its motion as if it's a joint, but technically speaking, anatomically, it is not classified as a joint. It doesn't have a synovial cavity, so it's not a synovial joint, and it's not connected by dense irregular connective tissue or cartilage, so it's not a fibrous joint or a cartilaginous joint. So we describe it as a joint because we need some way to describe the relationship between the scapula and the thorax and the movement that happens there. The glenohumeral joint, that is our fourth joint of the shoulder. It's responsible for most of the movement of the shoulder that we describe. So flexion, extension, add and abduction, internal and external rotation, circumduction, horizontal add and abduction. Those are all actions of the glenohumeral joint. Actions of the scapulothoracic joint would be like elevation, depression, upward, downward rotation, protraction, and retraction. The glenohumeral joint is a ball and socket joint, so it is triaxial, and it's the articulation between the humeral head where it sits in the glenoid fossa. And again, we'll get into more depth and detail on the anatomy of these joints later on in the course. We'll talk about the labrum and more detail here. The elbow is another joint complex made up of three separate joints. These three separate joints are all very close together, and they share one big joint capsule. Okay, so although there are three separate articulations that are part of the elbow, they all share one big synovial joint capsule, so all three are synovial joints. So that includes the superior radioulnar joint that's synonymous with the proximal radioulnar joint. I don't care which term you use. It's a pivot joint, so it's uniaxial. It only moves in one direction, and its action is in pronation and supination of the forearm. Okay, so it's the articulation between radius and ulna at the proximal end of those bones. Then we have the humeroulnar joint. That's the articulation between the humerus and the ulna. It's a hinge joint, so again, it's uniaxial, but in this case, its actions are flexion and extension. And then the humeroradial joint, the articulation between the humerus and the radius, again, is a hinge joint. And that's so the humerus, the humeroulnar and the humeroradial joints together, they're both hinge joints that both collectively participate in flexion and extension. So whenever we describe flexion or extension of the elbow, we're describing flexion or extension of the humeroradial and the humeroulnar joints together. And then the superior radial ulnar joint and the inferior radial ulnar joint together are responsible for pronation and supination of the forearm. Okay, so for the wrist and hand, we have first the inferior radial ulnar joint, which again is synonymous with distal radial ulnar joint. That is just like the superior version is a pivot joint, it's uniaxial. So together, the inferior and superior radial ulnar joints are responsible for pronation and supination. Then the radiocarpal joint, that is the articulation between radius and scaphoid and lunate, two of our carpals. So when we move the wrist like this or like this, those are actions of the radiocarpal joint. So that is a condyloid joint. So we have the dominant action is flexion and extension, and then the secondary non-dominant action is add and abduction, or ulnar and radial deviation. Intercarpal joints are also condyloid joints. Those are the joints that occur between the carpals within each row. So we have 2 rows of carpals. We have 8 carpals in each wrist altogether, 2 rows of 4. And so the articulations between each of the 4 within a row, those are the intercarpal joints. Then we have the midcarpal joint, it's another condyloid joint, and that's the articulation between the 2 rows. Okay, so 2 rows of 4 carpals each, and the articulation between the first row and the second row, that is the midcarpal joint. Then we have carpometacarpal joints. Those are the articulations between the carpals and the metacarpals. Those are all condyloid joints, except for the first CMC, that is a saddle joint. So the carpometacarpal joint at the thumb, the first digit, that is a saddle joint, but the rest are all condyloid joints. So that's the articulation between the distal row of our 4 carpals and the metacarpals. The intermetacarpal joints are the articulations between each of the bases of the metacarpals. So the bases of the metacarpals are at the proximal end, the heads are at the distal end. And so at the proximal end, right near where all the metacarpals articulate with the carpals, each metacarpal articulates with its neighbors. Okay, so all of the bases of the metacarpals articulate in the lateral direction with each other, and those are all the intermetacarpal joints. Those are condyloid joints. The interphalangeal joints are hinge joints. Those are all the articulations between each phalange. The joints of the wrist and hand are capable of varying degrees of flexion, extension, and add and abduction. So the hinge joints, the interphalangeal joints, those are all hinges. And you know what we're missing here are the metacarpophalangeal joints. Those are the articulations between the metacarpals and the phalanges. Those are also condyloids. So where we can go like this, that's add and abduction of the metacarpophalangeal joints, and then flexion, extension of the metacarpophalangeal joints. So almost all of the joints in the wrist and hand are condyloids that have flexion extension as their primary action and add and abduction as their secondary, except for the interphalangeal joints are hinges. And then the first CMC way down here is a saddle joint. The first digit, so the thumb, of course, is also capable of opposition and reposition. So opposition is where the thumb comes across to contact another digit. Reposition is when it goes back to anatomical position. So opposition, reposition, opposition, reposition. And that is unique only to the thumb or the first digit. Okay, moving down to the lower extremity, the hip complex is made up of three separate joints. All the movement of the hip that we described, that is movement of the acetabulofemoral joint, so our ball and socket joint of the hip. So that's the articulation between the acetabulum, that's the socket of the hip, and the head of the femur. The sacroiliac joint is the articulation between the sacrum and the iliac, or the ilium. Um, so it starts as a planar synovial joint, so like a planar or gliding synovial joint, and over time it converts partially into a fibrous joint. So in children, it's completely synovial. There's a lot of movement there. And then as time goes on and we develop and grow, the part of the joint starts to turn into a fibrous joint. So it becomes increasingly more fibrous with age. So hopefully we always maintain some amount of the synovial portion of the joint, but in somebody who's very sedentary and growing in age, eventually it will become completely fibrous. This is an example of use it or lose it. If we're not using the mobility of the sacroiliac joint, it will eventually lose all of its mobility and become fibrous. And so it'll become amphiarthrotic, so only very slightly movable rather than a freely movable synovial joint. We can avoid that. Age is not the only thing that causes that. We can avoid that by maintaining our activity and staying active and not being too sedentary. It'll keep the motion there and maintain the synovial portion of the joint. So again, we'll get into that on a deeper level later on in the course. And then the pubic symphysis, I talked a little bit when I talked about symphysis type joints, but it's a symphysis joint. It's a cartilaginous joint joined by a disc of fibrocartilage, and that's articulation between the left and right pubic bones. Okay, moving on to the knee. The knee is another joint complex made up of three different joints that all share one large joint capsule, just like with the elbow. So the tibiofemoral joint, that is the articulation between the tibia and the femur, and that is the hinge joint of the knee. So all the flexion and extension that we have in the knee, that is all flexion and extension of the hinge joint. So when we're naming actions or naming the joints that are moving, we're naming, flexion or extension of the tibiofemoral joint because that's the actual joint that's moving. The patellofemoral joint is the articulation between the patella and the femur. So the patella, like I talked about in another video, is a sesamoid bone embedded in the quadriceps tendon. And so it sits inside the tendon and then glides up and down in a ridge. There's kind of a groove in the femur. So it glides up and down within that groove on the femur. So it's a plane or a gliding joint. This is an example of one that is biaxial instead of triaxial because most of them are triaxial, but this one's biaxial because it just glides up and down on the femur during flexion and extension, and then also has a little bit of side to side, lateral medial movement. So biaxial only here. And then the superior proximal tibiofibular joint is also, that's our third joint that's part of the knee complex. It is a synovial plane gliding joint, and it is inside. Again, all three of these share one large joint capsule. So the knee actually has the largest joint capsule in the body, bigger than the hip or anything else, and contains all three joints inside. So this again is just a plain joint. So it's not participating in flexion extension or anything else. It's just gliding to allow for the normal movement of the other two joints of the complex. Okay, the foot and ankle, we have, again, this is another joint complex made up of three joints, two of which are synovial and one is fibrous. So the talocrural joint is the articulation between talus and the bones of the crural region. So if you think back to your anatomy class, I don't know, you might have covered anatomical regions. Hopefully you did, but everyone might have covered things differently. So the crural region is the region between the knee and the ankle. So the bones of the crural region are the tibia and fibula. So the talocrural joint, that's the articulation between talus, that most superior tarsal bone, and the bones of the crural region, that's the tibia and fibula. Okay, so where those three bones articulate, that forms the talocrural joint, and it is just a hinge joint. It's a hinge that does this, plantar flexion and dorsiflexion. Okay, so it's a hinge joint that does plantar flexion and dorsiflexion, the joint between talus and the tibia and fibula. The subtalar joint is a little bit more complex in its anatomy. That's the joint inferior to talus, the joint between talus and calcaneus. It's also sometimes referred to as the talocalcaneal joint. Those two terms are synonymous. I don't care which one you use. I always use subtalar, just that's my habit, but neither is more or less correct. So subtalar is the same thing as talocalcaneal. It's a bicondylar joint. So basically it's a condyloid joint, but where it has kind of two condyloids that sit next to each other like this. They make kind of like a V shape next to each other. So it's two condyloids or bicondylar, and that's where we have our inversion and eversion. So where the ankle's tilting side to side, inversion and eversion. So that is only happening at the subtalar joint. Okay, so talocrural joint, dorsiflexion and plantar flexion, subtalar joint, inversion and eversion. Then our third joint is the inferior or distal tibiofibular joint. And that is an example of a syndesmosis joint. So it's a fibrous joint that's joined together just by dense irregular connective tissue. So that's the articulation between the tibia and fibula at the distal end. And I think I mentioned this in another video that if someone has a high ankle sprain, what they've actually sprained is their inferior tibiofibular joint. As opposed to most other ankle sprains, just regular ankle sprains, usually they're happening on the lateral side of the ankle, and that's usually due to too much pronation or too much inversion of the ankle. So those are the majority of ankle sprains happening there, and then a high ankle sprain would be of the inferior tibiofibular joint. All right, so then we have many joints of the feet, just like we had many joints of the hands. So first we have the tarsometatarsal joints. So those are the articulations between the tarsals and the metatarsals. Those are all condyloid or saddle joints. And I guess I skipped over the intertarsal joints, just like we have the intercarpal joints. So we have articulations between each of the tarsals of the feet. So we have 8 carpals in each wrist. We have 7 tarsals in each foot. So then we have the articulations between the tarsals and the metatarsals. And then we have the intermetatarsal joints, just like we have the intermetacarpal joints. Those are the articulations between the bases of each metatarsal. And those are all condyloid joints. And then the metatarsophalangeal joints, those are the articulations between the metatarsals and the phalanges. Those are condyloid joints, just like the metacarpal phalangeal joints. And then we have the interphalangeal joints, just like we have in the hands. Those are hinge joints between the phalanges that are only capable of flexion and extension. All right, so moving on to the head and spine here. We have the temporomandibular joint. So there are actually many articulations of the skull and the face, so we're not going to talk about nearly all of them at all, but just really the more relevant ones. So a temporomandibular joint, often referred to as the TMJ, that's the articulation between the temporal bone and the mandible. So this is another sort of complicated one. It's a combination of a hinge and a plane or gliding joint. So we know that we can elevate and depress. That's the hinge action of the joint, the elevation depression. But we can also laterally deviate, And I may not have mentioned this in the joint actions video, but we can also protract, where we jut the jaw out forward, and a retract, where we pull it backwards towards us. So that side to side and front back, that's all action of the plane or gliding aspect of the joint. And then the hinge part is the elevation and depression, the opening and closing. Okay, the head and spine. Continuing on here, we have the intervertebral symphyses. So I mentioned that we have symphysis joints between every pair of vertebrae. I mentioned that in our in the fibrous and cartilaginous joints lecture. So every single disc is forming an intervertebral symphysis between the vertebra above it and the vertebra below it. So collectively, those are all the intervertebral symphyses. So those are symphysis joints, which are a type of cartilaginous joints. And then we have facet joints. So if we look at the spine here, and we look at the posterior portion where we have the spinous processes and the transverse processes, and we have all the little facets that project superiorly and inferiorly on each vertebra. Those are where we have the facet joints. So those are all plane or gliding joints, and those are the articulations between the superior facets of a vertebra and the inferior facets of the vertebra above it. Okay, so each vertebra has, let's see, I wonder if I can point here, annotate. So each vertebra has, if you can see my little blue circle I'm drawing here, has the inferior facet on its inferior side and the superior facet on its superior side. So right where I drew that little circle, that is where we have a facet joint between the superior and inferior vertebra. So those are plane or gliding joints. So every vertebra, at least until we get to the very, very top cervical and the very, very bottom, each vertebra participates in 4 facet joints, 2 to its superior and 2 to its inferior. So we'll talk about those a bunch more when we get to that again later on, because those are joints that are commonly injured in whiplash. So somebody who has whiplash pain that goes on and on for a long time, often it's because they've injured their facet joints and maybe they haven't healed correctly. Okay, so that's all I have for you here, and I'll see you for the next video. Bye.